with specific reference to examining a case of cerebral palsy with diplegia. Now, as we all know, cerebral palsy is a multifaceted problem. It's a damage to the growing brain, but because of that, it is not only the motor system which is involved. You may have problems in various systems. For example, the ocular. Eyes can be a problem, hearing can be a problem, speech can be a problem. There can be a lot of cognitive problems, psychological problems. So it's a multifaceted problem, and one has to examine the whole patient. Though we are focusing on the orthopedic management of diplegia, orthopedic examination of diplegia. So one needs to take a detailed history to come to know how the problem arose, why the problem arose, then the static clinical examination, and finally the dynamic gait analysis. Because with the history and with the clinical examination, you can reach so far, but there may be some parameters which the mind can overlook, which a computer can pick up, and that is why the role for a dynamic gait analysis. Now, I would stress on these 6 points on clinical evaluation, that is the tone and power, selective control, that is motor control, joint contractures, torsional deformities, balance, posture, equilibrium, ambulatory status, and gait. Now, tone and power. Tone is something which is very, very variable. The child, if he is happy and relaxed, the tone may be less. If the child is irritated, the tone may be more. So that we always suggest that you examine the tone twice, examine the child twice. You know, all know about spasticity, I need not explain, but there is something called as dystonia, which is involuntary and in which spasticity comes and goes during certain parts of the gait movement. This keeps on changing, so it's changing. The deep tendon reflexes are exaggerated when the pyramidal system is involved and normal or decreased when the extrapyramidal system is involved. Now, the importance of this extrapyramidal system involvement is that surgery is not very reliable when done for extrapyramidal problems. The tone is measured by means of the Ashworth scale from 0 to 5. So, first is normal muscle tone. Second is slight increase in muscle tone manifested by a catch during the end of movement. Third is spasticity, which is present for less than half the range, terminal range of motion. Then spasticity which is present throughout the range of motion, but the part can be easily moved. That is the type 3 or grade 3 spasticity. Type 4 is considerable increase in muscle tone, but passive movement is difficult. And type 5, where the affected part is held rigid in flexion or extension. The Tardieu scale is another valuable scale. Spasticity is dependent on velocity. When you do a fast movement, the spasticity occurs much earlier during the movement cycle, and that is called as R1. Then you subject it to a slow stretch, subject the affected part to a slow stretch, and then you get a catch, and then further movement is halted, that is R2. The difference between R1 and R2 is called as the dynamic spasticity, which means that you can reach a point up to R2. You can dorsiflex, for example, the ankle to 0 degrees, but when you do it fast, you will not be able to dorsiflex to 0 degrees. It may come down to -5 or -10 degrees. So between -5 or -10 to 0 is dynamic spasticity, which is a window of opportunity where you can try out drugs. Selective control is something which is impaired in cerebral palsy because there may be power, but the brain is not able to send the signals to the muscle, so that coordination is a problem. You ask the person, for example, to dorsiflex the ankle, he may not be able to do so. So power we can't rely on very well in cerebral palsy, but selective control is something very important. One, you have a scale here, there are many scales. 0, there is no ability, for example, to dorsiflex the ankle. 1 is partial ability, the person can dorsiflex, and 2 is complete ability. Now 1 is the partial ability. If I ask the person to bend his knee, in effect doing the silver skull test, he may be able to dorsiflex completely. But with the knee extended, 1 is partial ability and 2 is complete ability to isolate movement, which means he can do the movement quite well. Now joint contractures is something we are very familiar with, and a number of tests describe joint contractures. For example, the Thomas's test describes fixed flexion at the hip joint. It's not very reliable in cerebral palsy, and you have to do it very carefully. Stahelli test is in prone, so put the patient prone and then extend the hip joint, and the limit of extension is the amount of flexion deformity which is present. Duncan-Ellis test, press on the sacrum and then flex the knee. If the rectus is tight, the rectus will pull on the anterior inferior iliac spine, which will in turn tend to rotate and elevate the pelvis. So the pelvis gets hiked in a Duncan-Ellis test. Straight leg raising test, the opposite extremity is pressed down and then you raise the leg, take it up when the flexion just starts and then bring it back to a straight position. This is the straight leg raising test. The popliteal angle is suggestive of hamstring tightness. Also the straight leg raising, when it is impaired, is suggestive of hamstring tightness. Normal could be in the range of 50 to 60 degrees. In cerebral palsy it can be much lesser. So popliteal angle, you bend the knee to 90 degrees or even lesser, keep the hip elevated at 90 and then you extend the knee. And when you extend the knee you get a catch. Now the point at which you get a catch, that degree as compared to the vertical, it's shown on the diagram here. You compare it with the vertical and you get a catch at this point, and this is the popliteal angle. So knee joint contracture can be identified by relaxing the hamstring. So you extend the hip joint, you allow the ankle to go into plantar flexion, and even then if the knee does not straighten out, it means that there is a capsular contracture of the knee. Hamstring contracture is suggested, or tightness is suggested, by a lesser straight leg raising and a popliteal angle which is lower than the normal. Now I'll come to this bilateral popliteal angle in the next slide, what is called as the hamstring shift. You'll take some time to understand this. This is the way we do a normal popliteal angle. This is the way we do what is called as a double popliteal angle, which means you flex the opposite extremity at the hip. When you do that, whatever lumbar lordosis was there is eliminated. The ischial tuberosity moves downward, the hamstring gets more relaxed, and because of that you get a higher popliteal angle. Now this is popliteal angle 2, this is popliteal angle 1. One is with the knee extended, the other one is with the knee and the hip flexed. Now the difference between popliteal angle 2 and 1 shows you the extent of hamstring length which is present, which is getting lost in the lumbar lordosis. Now if it is more than 20 degrees, it means that a shift more than 20 degrees is suggestive of an excessive anterior pelvic tilt. Usually it could be because of weak abdominals, it could be because of weak hip extensors, for example. It means that the pelvis is going in lumbar lordosis, the hamstrings are not at fault. Do not lengthen the hamstrings. For example, in crouch, everyone feels that the hamstring is short and we must lengthen it. It is not so. You need to check for the hamstring shift. If the hamstring shift is more than 20 degrees, then usually it is not the hamstrings but some other area which is the cause of the problem. When you have 1 degree of pelvic lordosis, there is a 2 degree increase in knee flexion, because the pelvis actually keeps wounding round, it keeps winding. With a flexion deformity, for example, of the hip, the pelvis actually turns. When it turns, it causes the ischial tuberosity to move upward. The hamstrings are put on a stretch and you get a apparent knee flexion deformity. Phelps test is done in, this is for the adductors. So if you flex the knee and then you test whatever adductor opening is there is the true adductor opening. When you do it in extension, the gracilis and the hamstrings come into play and prevent abduction. So there is a difference. It tells you the importance of the gracilis, for example, when you do it in extension. When you do it in flexion, it is only purely the adductors which are responsible for limiting the abduction range. The Silvescoil test is well known to all of you. With the knee extended, the foot is in equinus. With the knee flexed, the foot starts dorsiflexing, suggesting that the gastrocnemius is tight. The soleus is okay, the gastrocnemius is tight here. Now torsional deformities, again we need to point these out very clearly. Increased femoral anteversion and tibial extorsion because of abnormal muscle forces, these happen. We need to evaluate hip rotations, the thigh foot angle and the bimalleolar angle. I'll take a few minutes more. Just go forward. So this is increased femoral anteversion where the knee points medially, points internally. That is increased femoral anteversion, and do a CT scan. This is what is shown. Tibial extorsion. So the tibia is straight. From down, as you go out, you find that the foot is turning out. Actually, both the malleoli are turned out. This is increase of tibial external rotation or tibial extorsion. So you have different parameters by which you can make out. Hip rotation can tell you. In increased femoral anteversion, the hip internal rotation is excessive. The thigh foot axis can tell you about the alignment of the foot in relation to the thigh. We'll just come to that. But before we come to that, femoral anteversion can be calculated by this test. You keep the patient prone, put your hand on the greater trochanter, turn the extremity in and out, internal and external, and there will be a point where you find the trochanter getting very prominent. Now this is the point, for example, at which the trochanter becomes very prominent. So from here to the vertical is the degree of femoral anteversion. This is quite a reliable test to clinically gauge femoral anteversion. So this is hip rotations, increase in femoral anteversion. So for example here, you feel the trochanter. If trochanter is most prominent here, and this is the angle which is formed with the vertical, that is the angle of femoral anteversion or retroversion, internal or external. This is the thigh foot axis. The thigh here, the long axis of the thigh and of the foot here, and the angle formed between the two tells you something about the tibial torsion or of problems with the foot. The bimalleolar angle is a very good index. You must know about this because it tells you about intrinsic foot deformity. You take both the malleoli, you draw an imaginary line through the malleoli, and then draw a line which is inclined horizontal. So if the patient is lying a horizontal line and the line of both the malleoli, and this angle can tell you about tibial torsion, whether any tibial torsion is present or not. You can extend this bimalleolar angle and draw the long axis of the foot. If the problem lies in the foot, the angle between the malleolar axis and the long axis of the foot will reduce. It will be less than 90, which means the problem is in the foot itself at a subtalar level. So these are shown here. I just skip this. Now last two areas, patella alta. You need to identify patella alta in a diplegic patient because it has a lot of implications. Patella alta can cause a extensor lag. It can cause pain, subluxation and patellar dislocation. The patella is placed abnormally high. Normally it is at one finger above the adductor tubercle, the superior pole of the patella. The adductor tubercle can be felt medially. Feel the superior pole of the patella. The normal distance is one finger. If it is higher than that, it means it's abnormal, and radiologically also you can correlate. This is a classic example of patella alta. Now foot and ankle, it's a detailed thing in itself. I really won't go into it, but it's very critical to examine this from all the sides, front, back and from both the sides, because planovalgoid foot is often a consequence in spastic diplegia. So you examine this very, very carefully. Lastly, about this balance posture, this can be impaired because of cerebellar involvement. You can get problems with balance and equilibrium. The ambulatory status, this is something all of you must know. The ambulatory status in cerebral palsy is given by the Gross Motor Functional Classification System, GMFCS. GMFCS are 5 types. GMFCS 1, where the child can walk unaided. GMFCS 2, on uneven ground the child requires some support. When he is climbing stairs he requires some support. Level 3, where he can walk a short distance unaided, but generally on uneven grounds of a longer distance he requires support. Level 4, they prefer to be taken care of, to be moved around in some form of ambulatory aids. And level 5, where even head holding, trunk holding is a problem. Lastly, gait, I leave that to Murli to cover because of shortage of time. So that was in brief about orthopedic evaluation of cerebral palsy, some of the areas which you must cover. I thank you very much for your attention.